The chair for today is Professor Beverly Hunt, OBE, founder of Thrombosis UK and Professor of Haemostasis and Thrombosis at Guy's and St Thomas's Hospital, London. Beverly is a global expert in thrombosis and acquired bleeding disorders. She has sat on multiple national and international guideline writing groups, has extensive clinical experience of thrombotic and acquired bleeding disorders, and runs a very active research group with over 400 peer-reviewed publications to her name. She's also chair of the steering committee of World Thrombosis Day and medical lead for ISTH 2022 coming to London later this summer, where I'm sure we hope to see many of you. So without further delay, I'll pass over to Beverly. Thank you.
So thank you very much, Jo. And this is a novel session. We want to talk about thrombophilia, but we don't want to do boring slides, and we want to have a highly engaged and fun session so that we can allow people to ask us questions and we can solve all your problems with thrombophilia. And it is quite a knotty subject. If nobody asks questions to start with, I will, and I'll also join in with the answers. So we've got two doctors with us who are very experienced in thrombophilia. The first is my colleague, Dr. Karen Breen. So she's based here at Guy's and St Thomas's Thrombosis and Haemophilia Centre. She's got a really strong interest in research, and she does trials in antiphospholipid syndrome and thrombosis, and is involved in a number of other trials. Her specialist interests are thrombosis and obstetric haematology, and most of her clinical work is thrombophilia. And then coming in from Addenbrooke's, we've got Dr. Will Thomas. So he also is a consultant hematologist with a major interest in thrombophilia. He also looks after those with bleeding disorders, and he's currently UK HCDO Centre Director. That means he's in charge of the haemophilia patients in Cambridge. He too has got an extensive research interest in clinical and laboratory hemostasis. So we have got two doctors who are relaxed and comfortable about thrombophilia. And we're expecting questions from healthcare professionals, and we haven't got any. I want you to put the questions in the Q&A area, and then I will pass them on. We will do our best to answer every single question. I think we have to start first, though, with a definition of thrombophilia, because I think that's a stumbling block for many people. Will, what's your definition for thrombophilia?
Nothing like being put under the spotlight. But I suppose I'd describe it as a genetic or acquired propensity to thrombosis. But that's quite interesting, because could you then call immobility a thrombophilia, because that's an acquired propensity to thrombosis? So I suppose if I had to go one step beyond that, I'd say something specifically affecting the coagulation part of Virchow's triad instead of the vessel wall or stasis.
And what about, because some of the definitions just say risk factors for venous thromboembolism rather than arterial as well. What do you think about that?
We see quite a lot of patients with arterial thrombosis. So I'd definitely put them, thrombophilia, can affect arteries and veins for sure, and capillaries.
Right. So Karen, do you agree with him?
To a degree, I guess. Obviously there's, as I'm sure Will probably allude to later as well, but there are certain conditions, particularly the inherited thrombophilias, that we know seem to predispose a lot more to venous thrombosis rather than arterial. And the typical acquired conditions such as antiphospholipid syndrome can particularly cause thrombosis in arterial vessels as well as venous. So I guess if you do have those patients who you get referred that have an arterial thrombosis, often we're thinking, well, there's no point doing an inherited thrombophilia screen in these patients because there's no real association. So you are thinking of antiphospholipid syndrome and the more kind of rare conditions such as myeloproliferative disorders or paroxysmal nocturnal hemoglobinuria. So yeah, so that's I guess how I would summarize that.
Okay, so I think that we all agree that an inherited thrombophilia group of tests is looking for people with a predisposition to venous thromboembolism, but the others, and the others mainly include antiphospholipid syndrome, can be predisposed to both arterial and venous events and even microvascular with antiphospholipid syndrome. Can we agree on that?
Yep.
Okay. So if we agree on that, if we have an inherited thrombophilia set of tests, and I say set of tests and I don't say screening, because we know that if we do thrombophilia testing, we won't pick up everybody who's got inherited predisposition to venous thromboembolism. What would you put in a classic set of tests? Which are the tests you're going to do?
Shall I take that first?
Yes.
So typically, and there can be a bit of controversy here, I guess, that will probably be borne out in our later conversations. But typically these days, the tests that you would include for an inherited thrombophilia screen would be to check for factor V Leiden, heterozygosity, and usually the screening test for that is by doing an activated protein C resistance test, and you're getting a ratio to try and help you decipher whether the mutation is present. Then you're looking for the prothrombin G mutation, protein C and protein S levels to give you an idea if there might be protein C or S deficiency, and then looking for patients who might have antithrombin deficiency, for example. Then where it gets a little bit more tricky, and I'm not sure if these are even still included in any of the screens, would be the MTHFR mutation. And certainly I know, Beverly, as you're well aware, that's disappeared from our routine set of thrombophilia screening because the evidence is just not there for its association with venous thrombosis. So that's usually the kind of typical set of blood tests that you would do for an inherited thrombophilia screen.
So Will, do you agree?
The question is, I'd step one step back and say, should we even be doing the tests?
Good. That's a very good place to start.
Because I'm not going to deny I've ever done them, because that would be not truthful, but seldom are they done in my practice, because they simply provide an uncertain measure of risk, and we don't know what to do with these tests in the vast majority of patients. So I'd actually just go one step back. I agree with Karen on a philosophical level. They are the classical tests, of course, and my practice would mirror Karen's, but the tests are nearly useless in nearly all situations, barring a few very small.
Okay, I just want to pick up on MTHFR, because World Thrombosis Day is going to issue a call for action that everybody removes MTHFR from their set of inherited thrombophilia testing, because it's got such a minor risk factor for venous thromboembolism. Nobody seems to understand it, and so it just needs to come out. So we agree, and we've got that set of tests. But as you say, Will, they're of very limited value, because if we had 100 people who had had a clot and they had strong family history, and we use that set of tests, we'd only perhaps label less than 50% of them with that modern thrombophilia testing set, because there are clearly things we don't know about thrombophilia and that have yet to be discovered. And I mean, it's coming through all the time. And I think I've just read JTH, and JTH has come up with, thrombomodulin polymorphisms are risk factors. That's fine, but we can't check for them routinely yet. So if we come back to when you use thrombophilia testing, do you follow NICE guidance? Can I remind everybody what NICE says? NICE says that the only time to use inherited thrombophilia testing is when we've got somebody who has had a VTE that is unprovoked, and there's uncertainty about whether to continue with anticoagulation, and they have got a family history of venous thromboembolism. Will, what do you think about that definition?
Yeah, I'm not sure I subscribe to NICE's inherited thrombophilia testing there, because we know from back in 2003 when Trevor Baglin, my predecessor, published his paper in the Lancet about VT recurrence risk, that recurrence risk is not determined by your inherited thrombophilia status, but rather by whether your clot was provoked by a major transient risk factor, a weak transient risk factor like a calf injury, or it was unprovoked. So I've always...
Sorry, Karen, would you mind switching off your microphone until you talk? Because I think we're getting your background noise. Thank you.
And a search on Google will show quite a lot of studies that show that inherited thrombophilia testing just can't predict your recurrence risk. So we are stuck with Trevor's approach from 2003, as things stand, with classifying your recurrence risk in a traffic light system between strong transient risk factor, weakly provoked, unprovoked, and persistent risk factors. And so I do not use these tests in that fashion. The one test I do think is quite helpful is antiphospholipid antibodies in patients with unprovoked clots, where you are considering stopping anticoag, because the finding of positive antibodies adds an inherited thrombophilia that would steer you away from stopping anticoag.
Okay, you say adds an inherited, you mean acquired factor?
Did I say,
Yeah,
sorry, antiphospholipid antibodies clearly acquired. So it's the ones, but that's the only thrombophilia I screen for in VTE routinely.
So I have to push you here, because supposing there is a very strong inherited VTE rate, and you might miss antithrombin deficiency, and that has implications for how we manage our patients, and that obviously they won't do so well with heparin. So do you really not, in the situation NICE mentions,
so
inherited thrombophilia?
Yeah, so if someone has a very strong family history, antithrombin, I agree, is the one that you might look for. The problem, and maybe protein CNS, I guess, but the problem with it is I see thousands of new referrals, literally like 1,000 a year. And when we looked at this previously in an audit, you almost never find antithrombin deficiency. In a very thrombosis-prone family, maybe, but they are very rare.
Yes, but that's not an indication not to test for them, because you need to pick up the ones that have it. Karen, what do you think?
Yeah, I mean, I guess it's a bit tricky, you know, because like Will says, it is relatively rare, but you don't want to miss it. So I probably operate slightly differently, that, you know, I wouldn't want to miss an antithrombin deficiency. And again, you know, particularly thinking of the cohorts of patients that we would quite often see, like a young woman of childbearing age, for example, that could have significant implications. So you might maybe nuance in terms of the individual you're seeing then, you know, obviously if it's an 80-year-old man who's presented with his first thrombotic event, you might maybe not have such sort of loose criteria, but I think in the younger patients, I would generally just screen.
Sure, but Karen, can I put that back to you? If you're an unprovoked 25-year-old man with a submassive PE, women, I think, are different because of pregnancy and antithrombin. Like, it's critical to pick up antithrombin. That's the one thing all women of childbearing age that have a clot, I do an antithrombin, irrespective of whether they're going to stop anticoag or not, because it's such a game changer finding antithrombin deficiency for pregnancy. It completely changes what you do. But if you're a 25-year-old man and you have an unprovoked submassive PE, then your recurrence risk is more than 5% per year off anticoag. And irrespective of your antithrombin status or not, you have an indication to be offered indefinite anticoagulation. So therefore, what's the benefit to that person? That's what I'd put back to you.
Only if they've got a family history would I do antithrombin.
Sure. Can I just put it back to you? But what's the benefit to that patient?
The benefit to that patient is if they have a recurrent event, that when you put them on heparin, you give them adequate heparin and you monitor their levels. And also if they have family and they have a daughter, there is an argument for going ahead and looking at the rest of the family, or at least giving the person with antithrombin deficiency a letter that they can pass on to their relatives who may be affected.
Do you mind? I don't want to go too far down the rabbit hole, but in doing so, you're undertaking a pseudo. There are quite big implications for the rest of the family.
Yes.
Yeah.
There are. And I think I'm perhaps influenced by my practice, because I seem to see people after they've seen other people and they were diagnosed late, and they've already been damaged by having had several clots before Penny's clot with a clinician that they might have antithrombin deficiency. Karen, you better mediate between the two of us.
I mean, I completely get what Will's saying. You know, I think if you're looking at it as a population screening type thing, or you're even trying to maybe direct your screening a bit more from a financial perspective, it possibly doesn't make sense. But from an individual perspective, you know, I think we're all a little bit afraid of missing those cases whereby it may have made a difference. So, you know, I guess that's probably where I would come in and sort of say, well, we have the test available, and if you did miss one case, well, then it's kind of worth it to check for it in most of these patients.
Okay, so that we have to agree to disagree here. I'm going to move us on. So there's a question here. It says, are there any thrombophilias, apart from antiphospholipid, that might make you not wish to stop anticoagulation, e.g. high levels of factor VIII? So that's all it says. And I think it means, are there any other thrombophilias that might make you want to continue with anticoagulation? Does anyone have a wish to continue anticoagulation if someone's got high factor VIII levels?
I guess it probably somewhat depends on the thrombotic event, doesn't it? You know, there's other factors that you would take into consideration. You know, what was the original VTE episode? You know, is it a submassive PE versus a CAF DVT? How old is the patient? You know, because if it's somebody who's a bit older and they've got high factor VIII levels, is that age related? You know, there's lots of different factors I think you have to take into consideration. So in isolation, I think the short answer is no, but would consider it amongst all the other factors in the presentation with the DVT.
So this question really stems from this other one, which I should have asked you first. So the European Society of Cardiology suggests patients who are carriers of some form of hereditary thrombophilia, notably those with confirmed deficiency of antithrombin, protein C or protein S, and patients with homozygous factor V Leiden or homozygous prothrombin 2210 are often candidates for indefinite anticoagulation treatment after a first episode of PE, occurring in the absence of any major reversible risk factor. So that's that diverts itself from BSH guidance. Will, do you want to take up on this? Because do you leave patients who've had an unprovoked event who have factor V Leiden in the homozygous state, leave them on long-term anticoagulation?
We don't test for inherited thrombophilia routinely in patients with unprovoked VTE. So the stratification on the decision for limited duration anticoagulation versus indefinite anticoagulation is made on the clinical circumstances regarding the clot, and whether, because in that ESC guidance, there's a traffic light system for VT provoked by a strong transient risk factor versus weakly provoked versus unprovoked versus provoked with persisting risk factors. And you can quote from that ESC guidance a recurrence risk per annum. And if you also calculate a has-bled score, which the NICE recommends that we do, you can quote the patients an annual risk of recurrence and a bleeding risk and let the patient make up their mind. Inherited thrombophilia testing has not been shown in sort of it's not really been shown to predict the recurrence risk. I accept there are these very limited, I completely accept your argument on antithrombin. I understand where you're coming from, and I'm playing devil's advocate when I say what I say, but there are a tiny number of families and cases. So that's why I don't routinely test. And to me, it confuses patients, because if they have a normal screen, then you can send out the wrong message, and actually they'll hear my recurrence risk is low, but actually if they're a man, they're overweight with post-thrombotic syndrome, their recurrence risk will be high if they've had an unprovoked clot, irrespective of their normal thrombophilia screen. Does that answer the query?
Oh, well, it's beautifully clear. You're a purist. You're not doing thrombophilia testing. You're making a judgment on the clinical event. And if it's unprovoked and it's severe, you're just leaving on long-term anticoagulation. Is that the nub of it?
Yeah, and I think it's about communicating risk and giving patients sufficient information to be able to make up their mind dependent upon the recurrence and the bleeding risks.
Great, so very clear view. Karen, what about you?
So I'm just going to come in maybe a little bit more on what you've said, Will, because I think sometimes it can be really quite difficult now that we're sort of back to seeing patients face to face a bit more as well, where you have a patient sat in your clinic room and they're a young patient, they've had an unprovoked submassive PE, we'll say, and they're sort of sitting there, you know, wondering why has this happened, and this comes up time and time again. So how do you handle that, where somebody says, well, why has this happened? And I appreciate that in, you know, generally 50% of the time we won't find anything. But how do you handle those cases where they would better deal with their diagnosis if they at least understood that, oh, I had this tendency that maybe explained my first event?
Yeah, so I don't think the testing does help, because 90% of people with Factor V Leiden heterozygosity, I think it's 90%, never get a thrombosis. There's a review article which states that 50% of people by 50 will have a clot that have protein S deficiency. So actually finding a hereditary thrombophilia does not explain their clot. I try to be honest and say in 2022, the state of the art science is that we do not know why you had your clot, and I wish we knew. And that's a research question, you know, and that's really frustrating.
But do you carry on and say, but you clearly have sticky blood? You must have, because you've had a clot and we can't find any other reason. And therefore we'd like you to continue anticoagulation. You do it in that way, do you?
Correct. Well, I'm not correct, because as in, yes, that's what I say, because I don't know if that's the correct approach, but some patients psychologically really struggle with that, don't they? Yeah.
I think that there's that thing out there that people just want a diagnosis. They want to be pigeonholed so that they can go home and say, so actually this is what I've got, and have that to explain it. Although quite often, say you find Factor V Leiden, it doesn't explain it all entirely, but they feel comfortable with that. And it's this issue about dealing with risk that the general public aren't so hot on. And I don't think that any of us are particularly hot on. We want to know, rather than being told, well, you've probably got sticky blood and you need long-term anticoagulation. Okay, so there's a cracking question here. It says, what do you say to someone who demands a thrombophilia screen? This person uses screen. I don't use the word screen because you're not screening. It's not good enough to be called a screen. What do you do when someone demands thrombophilia testing? Karen, what do you think?
I should now say I need to send you to my colleague, Dr. Thomas in Edinburgh, and he can answer your question. So I guess I would always kind of come back with a rhetorical question, you know, a bit like Will has just said, really, and say, well, what do you think that that test is going to tell you? Because you'll have, I would hope by that stage, sort of had some discussion around what the provoking factors are for their presenting thrombotic event. And so therefore, you know, usually my approach is to say that, for example, if you did have somebody who has, we'll say, a heterozygous factor V Leiden mutation, that you'll say, well, look, you have this possible tendency to have an increased risk, but actually in most cases it's multifactorial, and it may be the fact that you were, you know, sat at your desk not moving around during lockdown, or, you know, that approach really. But yeah, I think in short, I would always try and push back and say, unless I have a good reason to perform an inherited thrombophilia screen, you know, I don't think we can offer that in this setting. If, you know, if it's not in the setting of a non-provoked.
And you, Will, how would you manage the demanding patient who won't go home until you've done the blood tests?
Yeah, so I'd say the blood test is extremely unlikely to influence management, but if you're very keen, I'm happy to do it, with the caveat that it's positive in at least 5% of patients, more like 25% if you've had a clot. There's wider implications for your family if we find a positive result. You may have to, you might want to correct me on this, implications for declaring it for insurance purposes. Please correct me if you don't have to do that. Also, occupational consequences if you're found to have protein C or S deficiency. I don't know the answer to this, but can you join the police? I don't know. So if it's the fallout, and if you do find that you are a factor V Leiden heterozygote, and then you tell all your family, the anxiety, the referrals generated. So it's about careful counselling. Having said that, few people that see me ask for screening.
I always hide behind nice guidance if someone asks for family screening for factor V or prothrombin 22 and over, because it says you should not be doing family screening. So I can always send that referral back and remind them that NICE say we don't do screening for these common polymorphisms. Okay, so let's move on. We've got a question here. How do you approach the logistics of thrombophilia testing on anticoagulation? Will, would you want to take that?
Yeah, so it's a good question, because for most, so let's assume all the patients are on DOACs nowadays instead of warfarin, because that's the reality. The problem with the assays is they're affected by DOACs, because DOACs prolong clotting times, and all the assays are based on measuring clotting times. So our individualized approach in Cambridge is that we use a charcoal tablet to absorb the DOAC from the plasma. It's called DOAC Remove. There are other commercially available brands available if this was a BBC interview. And we absorb the plasma. We've published our data and it's been validated. There are numerous publications using this approach now, and we've not had any clinical instance related to it. And so we use charcoal absorption. So the patients do not have to stop their DOACs, and we can look up from their GP records, because we can now look at GP records from the trust to check what medication they're on.
What about antiphospholipid syndrome?
So we do the same. We check for a lupus anticoagulant by absorbing the DOAC with DOAC Remove, and then we check the lupus anticoagulant. And the solid phase assays, so your cardiolipin and beta-2 glycoproteins, are not affected by DOACs because they're ELISA assays.
Karen, do you want to add anything?
Yeah, I mean, I guess I was just going to maybe slightly further that conversation just in terms of when you would do that, because, you know, of course, with the EMA guidance to do with DOACs now, and for the occasional patient that you will pick up that, you know, you've got significantly positive antiphospholipid antibodies, or dual or triple positive, you want to avoid DOACs in that setting. And obviously we're concerned about missing those patients. So given the constraints that are on all our services these days, often it can take, you know, 10, 12 weeks before we will see these patients in clinic. So how soon generally, or for example, in your institution, Will, are they getting thrombophilia testing if they are getting any?
Yeah, so in our patient care pathway, and I'm not going to say it's 100% watertight, but routinely patients should be getting a cardiolipin, beta-2 glycoprotein and lupus anticoagulant on their DOAC 3 weeks after the event for patients with unprovoked VTE through our nurse-led clinic. And then if they've not, they come and see a doctor and have it 3 to 6 months later.
Yeah.
So hopefully by the time they see a medic, they're picked up.
Yeah, I mean, we aim to do that in Guy's and St Thomas's, but, you know, given the number of referrals, again, usually it happens by at least 3 months, but that's ultimately what we would aim to do as well.
Okay, next question. In those patients with VTE who are found to have an inherited thrombophilia, does it influence your decision on whether to continue full dose DOAC after 6 months or reduce to a lower dose, for example, rivaroxaban 10 or apixaban 2.5 BD?
Karen, do you want this one first?
Yeah, sure. I mean, it goes back to our original conversation that we probably shouldn't be checking them in the first place because they don't influence. So I think in short, no, it wouldn't, you know, generally influence my decision because it doesn't potentially push them into a higher risk of recurrence. So yeah, so that's how I would usually answer that question.
So you're reducing anyway after 6 months, or does it depend on the clinical?
Yeah, so yeah.
20 kilograms or
yeah,
that shouldn't influence.
Yeah, so there are the other factors. So, you know, obviously the rivaroxaban study talked about clinical equipoise. So you have those patients whom you might consider higher risk because of the nature of their presentation. So, you know, if you did have somebody, a young patient who presented with a submassive life-threatening PE, you would be quite reluctant to dose reduce those patients unless you were concerned about bleeding risk. So outside of that, generally, I will reduce most patients.
Will, would you vary from that?
Yeah, I'll just declare I've got conflicts from Bayer and Pfizer who manufacture rivaroxaban and apixaban for total probity here. But one of the issues with apixaban is that the summary of product characteristics stipulates that at 6 months for long-term VTE prophylaxis, the dose should be reduced to 2.5 milligrams twice daily. And I chair our Trust Drugs and Therapeutics Committee, so I'm extremely conscious of licensing issues regarding medications. So one of the issues is that there is not licensed room for discretion. Rivaroxaban does give some discretion. I think ignore thrombophilia because in a way that's a bit of a cul-de-sac here, a side alley. I think it's really difficult because we don't really know yet what the outcomes are if you keep someone on a low dose DOAC or full dose DOAC over many years. And we don't really have that data. Our service standard is for someone of a normal weight with a normal antiphospholipid antibody screen, normal renal function that's between 60 and 120 kilos. Our routine practice is to drop to low dose DOAC. But it's a really, I think we need some papers to show we need some trials looking between low dose and full dose to get more data, because at the moment we really only have the Einstein Choice study and the Amplify Extend. So I think there are 2 RCTs being done, one in Canada, one in France. I don't know when they're going to publish, but they should add. And so you can almost ignore the thrombophilia and say, actually, don't we need to know more just about this question?
Okay, now the next question, it's says, rather than testing for thrombophilia in women of childbearing age with VTE, doesn't mention whether they've got family history, is it sufficient to assume her children will be at risk regardless of all test results, i.e. no need to test her or any of her children? Oh, Will, this is for you.
It was quite a wordy, sorry, quite a long question,
is.
but so for women of childbearing age, I do test antithrombin because I'll
Yes.
just reiterate, it's such a massive game changer for pregnancy, and it's a really serious disease. I generally try not to test for the other inherited thrombophilias in women of childbearing age in an uncomplicated, straightforward circumstance, because it doesn't really change what you do. And if we do know a woman has an inherited thrombophilia and is having children, then my general advice is to leave testing until the child or that is old enough to make a decision on whether they want testing themselves. Controversially, even for antithrombin deficiency.
So I think the game changer was when we could do genetic testing, and so we can do a buccal smear on newborn without causing them any harm to see if they've got antithrombin deficiency, and that really would be my preferred way of managing antithrombin deficiency. And it's my belief, and I'm going to push this hard, that if you have a diagnosis of antithrombin deficiency, you should have molecular testing, because the different defects, depending on where they are, will behave differently, both thrombotic risk and also in pregnancy. And we need to build up information. So if it was antithrombin deficiency, I would offer mum a buccal smear. That is, if she hadn't had pre-implantation genetics, to make sure that she didn't have a child with antithrombin deficiency, which of course is now available. Okay, I think that we need to move on. Now, I think we need to hit on antiphospholipid syndrome. Karen, what are your thoughts on antiphospholipid syndrome and when we should test for it?
So we've touched on those patients who present with an unprovoked VTE. So for two reasons, I suppose number one is antiphospholipid antibodies will predict for an increased risk of recurrence. And then number two, as we've discussed, the role of direct oral anticoagulants versus a vitamin K antagonist. So antiphospholipid syndrome can cause numerous complications. So arterial and venous thrombosis. So moving on from testing and venous thrombosis, if you have a patient who is below 50 without any cardiovascular risk factors who presents with an arterial thrombosis, you should certainly think about testing for antiphospholipid antibodies in that setting. And then when it comes to the obstetric complications that can be associated with antiphospholipid syndrome, so for those patients who present with recurrent early pregnancy loss, so in gestation, that's usually less than 12 weeks gestation, or any women who have late pregnancy complications and they are late fetal loss, so anything beyond 12 weeks gestation, or have early onset preeclampsia, so that's preeclampsia before 34 weeks gestation, small babies, or late fetal loss, like I say. So those are generally the circumstances where you would need to check for APL.
Okay, should we be asking our stroke physicians to automatically look for antiphospholipid antibodies in young stroke patients?
So it's a tricky question, isn't it? Because, you know, in terms of how many patients will you pick up that may have APS, it's probably in the region of about 5-10% of young stroke. So I think for those circumstances and because of the increased risk of recurrence, then yes, you should, because it can be obviously very catastrophic if you have, albeit a single stroke event, never mind a second one. So yes, I think we should always be thinking about it in those patients.
Will, do you diversify from those views, or?
No, I agree with Karen's. I agree.
Fantastic. So then we come on to treatment, and we've got this question. How do you approach a patient who's been on a DOAC for their VTE and who's coming up for testing because they got an unprovoked event, who has not previously had a test for APL? Do you check it? What do you do with a DOAC if they have a single positive antibody? So they have an APL, but they only have 1 out of the 3 tests positive.
Maybe I can start with this one. So the question is, just to clarify, the question is that this is somebody who's been established on a DOAC for some time, and then suddenly they come up with a single positive antiphospholipid antibody.
Yes, they've prevented with an unprovoked event, and then you come to test them and they are single antibody positive.
Yeah, so I think this is definitely a less straightforward question, and I've looked at this in our cohort of patients at St Thomas's. So, I mean, we looked at approximately 60 patients who've been established on DOACs for anywhere in the region of between 1 to 10 years. And actually, the recurrence risk for those patients who have low titers, single or dual antiphospholipid antibodies is extremely low. Only 1 patient had a recurrent episode of thrombophlebitis out of that cohort. So I think you really have to carefully counsel your patients and at least make them aware of the risk. There is that EMA warning, and there's more evidence has come out, certainly for patients on apixaban, also since that publication came out a couple of years ago. So, like I say, carefully counselling your patients about the potential risk, that they know the signs to look out for with recurrent VTE. But I think you'll find that in practice, if you're offering warfarin as an alternative, many patients will say, well, actually, no, thanks. I'm very happy to stay on my DOAC and take the risk. Thank you very much.
Will, what are your feelings?
Yeah, so I start with the RAPS data, then I tell them the TRAPS data, then so RAPS was rivaroxaban, it was a UK study, it was people with VTE given rivaroxaban versus warfarin. The endpoint was a laboratory test and no patients in either arm had a clot. I tell them the TRAPS data, so people who are triple positive for antiphospholipid antibodies given rivaroxaban did badly compared to warfarin. Then I tell them the ASTRO-APS data, which was a mix of high-risk APS patients given apixaban, they did badly. And then I tell them about the MHRA warning, and I say, if you've had a single VTE and you're single or double positive, then rivaroxaban 20 is reasonable. If you're triple positive, then warfarin appears to be the better drug. But as a group, the kind of generic recommendation would be the gold standards warfarin, but that you may wish to continue rivaroxaban if you're single or double pos. It's pretty rare to pick up a triple pos isolated VTE. That they tend to get other things, but it does happen.
Okay, and in actual fact, if someone has a recurrent thromboembolic event actually on a DOAC, my first thought is, oh dear, they've got antiphospholipid syndrome. And I actually saw a new patient this morning who was covered in Livido and gave that history. So, and I presume they've got triple positive antiphospholipid syndrome, because there is that big cohort of patients around that time who did have recurrent events on DOACs and did have triple positivity.
I'd be really upset, and I can't guarantee it won't happen, but I'd be really upset if we had missed a triple positive APS that we're given a DOAC to long term. I can accept in the first 3 months they may not have had screening, but I'd be gutted if that happened in our hospital.
No, absolutely. I haven't seen it recently, but when you take history from people and you go back, they say, oh, 10 years ago I had an extra clot on rivaroxaban. Is there anything else you want to add about this thorny issue of when to use a DOAC in APS?
Just to caution, like arterial events and DOACs in APS are a red line. They have to be treated with warfarin. And I know this isn't licensed if they can't manage warfarin because of testing labile INRs. I personally give long-term low molecular weight heparin or fondaparinux.
So we are using lots of fondaparinux now in antiphospholipid syndrome, aren't we? And I think we were thrown into it partly by COVID and the wish to get people off warfarin. But I know that all of us, and perhaps not published enough about it, but we're using fondaparinux as an option to warfarin in APS. Yeah. Okay, so it's on my list of publications needing to be done, and we need to write it up because I think we have many patients on fondaparinux who've got APS now. Okay, here's a good one. Will you add antiplatelets to warfarin in APS? Who wants to start?
I guess I can start on that one. I think as a general rule, no, is a very short answer, because there's no evidence that you need to have an antiplatelet in addition to warfarin in most patients who have antiphospholipid syndrome. There are some patients that you will see in practice that despite good control of their anticoagulation, where they do have, you know, a good time in therapeutic range of at least 60 to 70% and have breakthrough recurrent thrombotic complications, that you will certainly consider adding an antiplatelet into those patients' regime if you don't have the option of increasing their target INR. But usually in practice, I would not routinely add an antiplatelet, and the evidence is not there.
Will?
It's tricky. I agree with Karen. The thing I find tricky, because the evidence just is not concrete, and I know this is controversial, is for someone with an arterial event, what the optimal target INR is. And I know that's something that causes a lot of the guidelines sort of leave it vague. You can choose 2.5 or 3.5.
Okay, yes, I think that St Thomas's, and also UCLH would go to 3 to 4 target every time someone with arterial events and who hasn't got a major bleeding history, but I appreciate other people start lower, but it's a belt and braces approach and seems to work. And the addition of aspirin to 3 to 4 means you do have a great increased bleed rate. And of course, we don't have any evidence that antiphospholipid antibodies actually work by influencing platelet activation. So I would argue no. And the European guidance on APS that's come from the rheumatologist says to use aspirin in those who are healthy and have antiphospholipid antibodies. And I can't agree with that either. We've got quite a lot of evidence now that if you're healthy, the benefits of aspirin antithrombotic effect is greatly outweighed by the bleeding risk. So I don't give aspirin to any of the patients with APL. Everybody seems to want something and the doctors want to do something, but really I think being conservative is probably better there. Will, would you agree with that, or do you give aspirin to those with APL?
I think it's really difficult because once something is in, I'm just being practical, but once something's in guidance, it's really difficult. And so personally, people who have never had a clot, but for whatever reason have been found to be triple positive, I talk to them about aspirin and say, the evidence is weak, but it's in some guidance. You might want to think about it. For a young, healthy person, they will, I know there's a bleeding risk, and in AF, completely different patient population, warfarin and aspirin, same bleeding risk. So, but the young, a lot of people tolerate low dose aspirin well, so it's something to think about. But like those kind of recommendations are controversial, aren't they? Because they're not based on RCTs.
There isn't a hematologist on the panel, and I don't think that they know the literature around aspirin in healthy populations and the risk of bleeding. And I would say if you want to do something, you could always use a statin, which we know has got antithrombotic effect, and we use an APS, and maybe hydroxychloroquine also has an antithrombotic effect as well as its anti-inflammatory effects. So I would go for a statin or hydroxychloroquine. There we go. Okay, we've got some more questions here. When do you look for PNH for your patients with unprovoked VTE? Cracking question. Thank you, Andriana. Karen, do you want to start?
I have to say rarely, because I think when we're talking about thrombophilias and case finding, certainly in my practice to date, I've never picked up one, and I actually don't know any other colleagues who have. And I know new guidance coming out from BSH will probably discuss that there is no real role for checking for rare disorders such as PNH, unless you've got a very strong clinical suspicion that they may have this underlying, you know, that they've got evidence of hemolysis or whatever. So I guess in short, I would say I rarely ever check it unless I've got a strong clinical indication too.
So
Well,
for unprovoked PE and DVT with a normal blood count, which they nearly all have, never. It's different for portal vein or mesenteric vein thrombosis or cerebral vein thrombosis, where if there are signs of hemolysis. Having said that, we have never picked one up in the last 5 years in Cambridge.
and in my history, I used to work with Professor Luzzatto at the Hammersmith, and there were wards full of patients with PNH and thrombosis, and all of them had some form of cytopenia at the time they had the thrombosis. So I think it's a fairly late event in the illness, and they usually have developed some movement towards a pancytopenia along the way. So I agree, if they've got a normal full blood count, it's unlikely. We've got a question here. Any long-term effects of fondaparinux if used in APS as you describe?
That's an interesting question, and I think certainly, well, there's no publications in terms of fondaparinux. I think the reason a lot of people are reaching to fondaparinux a lot more is because of the decreased risk of osteoporosis, although I appreciate even with low molecular heparin, there usually are some predisposing factors that would increase your risk of having osteoporosis. So in short, I'm not aware of any long-term implications of using fondaparinux, unless any Beverly or Will you are.
No, I mean, I think for the same reasons you prescribe it, which is trying to reduce osteopenia risk, that's why I've favoured it.
Okay. Here we are. What is your advice for triple positive APL antibody patients that have no thrombotic history and the menopause and want HRT?
Shall I go for this one? So
Let's go.
Yeah, so HRT is a bit like the pill in that it increases tablet HRT, your thrombose risk 3 to 5-fold. So there's no evidence here, but we've got patch HRT, and it's even on the NICE website. It says it does not increase your thrombosis risk beyond baseline, I think is the quote. So I generally say patch or vaginal HRT, so long as you you avoid the first pass metabolism. Yeah, and I've never had a problem with that, and GPs seem very happy with the advice.
And you're right, if you go to NICE, if you look at the inserts on all the medications, all of the patch HRT says there's an increased risk of VTE, but it's a lie. And last week, there is a recorded talk from Dr. Louise Newsom from the Menopause Society, I think she called a menopause charity, just walking you through the risk of VTE with patch HRT, i.e. there isn't any risk and it's the one to use as opposed to oral. Next question, there's 2 more and then we're stopping because we're running out of time. Do hemoglobinopathies increase risk of thrombosis, e.g. sickle? And if so, should we look for it in the appropriate population?
Karen, I go
Okay.
for it.
Yeah, okay. Well, I can start at least.
Question, really.
Yeah, so thalassemia, generally, no, it's not particularly associated with an increased risk of thrombosis. But sickle cell, and I suppose here we're really talking about HBSS disease, it can be associated with an increased risk, but that's generally in times of a sickle crisis, for example. I have to say, outside of patients who present with sickle crises or they're an inpatient for another reason, don't generally tend to have an increased risk of thrombosis. So they're not somebody that you would necessarily keep on long-term anticoagulation outside of that event. I don't know what the other panelists think.
Cambridge, I mean, to be very frank, Cambridge isn't the most diverse place to practice. But in reality, most adult patients, because I don't treat children, so most adult patients will know whether they have sickle cell anemia by the time they get to your thrombophilia clinic. It's not like it's going to be a surprise. But if I saw someone that I thought sickle cell anemia they may, because some patients are diagnosed much later in life, I'd test them as a matter of sort of being a good hematologist, if you know what I mean, not just because of thrombophilia, but it's not a thrombophilia test.
And we do in our clinics have a couple of patients with sickle cell. One's got antithrombin deficiency, another's got protein C, another's got protein S deficiency. So just because you've got sickle, you shouldn't stop there. You should have a look round as well. Chronic hemolysis is really slightly prothrombotic. So if in doubt, I'd use thromboprophylaxis. And then I think I'm going to go for the last question. We recently had a 40-year-old female smoker who had ischemic stroke. She was diagnosed with paroxysmal AF and was also triple positive for APL. What would you warfarinize her with? Would you go for 3 to 4? Karen? I mean, it's a bit bold, isn't it? It's difficult.
Yeah.
So I think you'd want to know a bit more about the patient, but what would your gut feeling be?
It's very hard not to, I think, is the short answer. I thought they were going to say she also had a PFO, which, you know, was going to completely complicate matters. But yeah, I think, you know, I guess you'd want to think about the presentation. You know, is there, on their MRI, you're looking at their sort of baseline. Are they somebody who seems to be like a vascular path? Or are you thinking a lot more about other cardiovascular risk factors because they're a smoker? But if you have somebody who's triple positive and they remain persistently triple positive, I think I'd find it really difficult not to anticoagulate that patient.
So you're playing it safe. Will, are you going to play it safe, or are you going to...
Warfarin with a target INR of 2.5.
Okay, so there we are. We have division among the experts, which is exactly how we should end. And I want to thank you both. I sort of tortured you a bit with questions, and you've held up valiantly, and you can go away and have a cup of tea or whatever your poison is. Thank you very much for submitting yourself to this session. Thanks too for the audience. You've got a healthy audience out there who've come up with some great questions.